Thank you, Dr. Somshekar. That was the simplest way of putting what overhead and corvus was. And as Dr. Dhanraj has put up, the difference between IOP measurement and comparing it with the gold standard, that's application, GAT. What was the difference? Anyway, early morning, too many values to remember. I know it's not really possible for the first time, but once you keep talking about this overhead and corvus, start discussing it, that's when you will start remembering this normal values. That's how you start comparing whether it's high, low, or normal. Anyway, I don't have any financial interest with this machine or any product. Actually, corneal biomechanics is a science that studies the equilibrium and deformation of tissues. To put it in simple English, overhead has been clearly explained now, which just measures the viscous and the elastic qualities with a calibrated air pulse. Why calibrated? Because we need to measure. Simple. So overall, the capacity of the tissue to recover from its original shape after external force is applied is what this corneal biomechanics is, which has been put into two different things, which are corneal hysteresis and resistance factor. Corvus has been explained in detail. Thank you. I will not go into it. So, where it is used, basically the device uses this application of corneal high pressures. Anyway, usefulness of this device, again, at least Dr. Dhanraj has shown, compared to other tonometers or compared to ORA to GAT, this correlates much better. There are other ways of measuring corneal biomechanics other than these two, but these are difficult to understand, so not frequently used also. So there are shear wave propagation imaging and OCT, which uses a special software for that. Anyway, here I will be talking of this use of corneal biomechanics in corneal pathologies. All this time you have heard about IOPs, but here I will be talking of corneal pathologies, but how the hell is it related? Once in a normal cornea you can measure with any instrument you have, but once the cornea is abnormal, that's when the problem starts with what you measure. That's why all these equipments are coming to the market. Fine, but none of them are accurate even now. So in keratoconus, as you know, it's a progressive disease, problem with the collagen network. So since essentially it's a stromal problem, and Dr. Satya has clearly shown the amplitude deviation with a normal corneal stroma and with a weaker stroma. So the changes are, we get early changes with these machines so that the disease can be picked up earlier. So these instruments can be used in the clinical practice also to detect diseases at the earliest stage itself. Most commonly in our place we use it for post-collagen cross-linking. Many studies have been done. One I have cited here. Basically there is a significant increase in biomechanical properties after cross-linking. That's the entrance of the study. Basically this cross-linking, that's the C3R, what we call, do actually help. But again, not in 100% of the patients. But something is better than nothing. I don't think we have any chance to stop keratoconus progression, or most of them are in trial and error phase. So this biomechanics was also checked with other corneal pathologies. Most of you will know that keratoconus, post C3R are the two most major places where this corneal biomechanics have been studied in detail. There have been other studies where corneal biomechanics have been studied with other dystrophies and corneal pathologies, where it has been shown that corneal biomechanics with CH and CRF both are reduced with corneal dystrophy. Main reason not known, most probable cause is the corneal thinning that's associated with that, especially the macular dystrophy. In Fuchs, again, the normal which is supposed to be 10.3, here it's reduced to 6.9. So, why it's reduced? No answers yet. We need to find out. But compared to normal eyes, the Fuchs dystrophy patients do have reduced corneal hysteresis and resistance factor. After keratoplasty, yeah, that's really a nice topic to talk about. But since we are using a totally different normal tissue, what should be the reaction? Nobody knows, because we also have corneal scarring along with it, and there is peripheral rim of the original tissue left. So, but the studies have found that CH and CRF approach almost near normal range after penetrating keratoplasty. So, how about post DSAK? Again, with keratoplasty, full thickness keratoplasty, it has shown near normal values, but with these procedures, it's again showing less values. So, basically, corneal biomechanics decreases with DSAK. And comparing DALK and penetrating keratoplasties, the CH and CRF were significantly lower in penetrating group compared to DALK group. Again, all these studies have limited patient numbers and only 1 or 2 studies. We need a larger randomized clinical trial to give you an opinion whether what exactly it is. Post-LASIK, of course, everybody knows it decreases because we are burning out some of the tissues. Thank you. There is one more talk by Dr. Rajesh. After that, we'll conclude the session and we'll take questions of the whole session. Thank you.